Good morning, good afternoon, good evening, and thank you so much for this very special and wonderful event organized by the ACNS and the FLANC Association. And today we have is an honor for us to invite Professor Luis. I think Luis, of course, without without formal introduction, we know him as president of of the WFNS, and he's very well renowned teachers. And I think we all meet him from different meetings all around the world. And but personally, I'm so glad to see him again. And I still remember when I met him in Surabaya and during the Congress, and I really learned so much from him. And today, Luis is going to again a webinar and to teach us again. Maybe shall I invite Professor Baba to speak a few words before the webinar?
Okay. Yeah. Okay. Good morning to the people in Latin America. Good evening to the people here in Asia. I'm now in Central Asia. I'm in Kyrgyzstan.
Really?
Yeah, in Kyrgyzstan.
How's everything in Kyrgyzstan? Is it
good? Professor Juan Luis Gomes Amador, 5 o'clock in the morning, no?
It is 4 a.m.
Oh my God, 4 a.m. Thank you very much, Juan Luis. Thank you. I really appreciate
Thank you so much. Thank you very much.
Professor Cato, thank you very much for the work that you are doing, not only in ACNS. Thank you very much for the work you do in your entire life.
You also.
Help the young neurosurgeon and help the team.
Thanks.
We need people like you to keep the real neurosurgery alive in this bright young generation that is coming.
Yes.
Thanks, Prof.Andrei, Joaquim. Andrei is a brilliant Brazilian neurosurgeon specialized in spine. He's very well recognized neurosurgeon around the world. He traveled a little bit less than me, but he traveled a lot around the world and gives and totally dedicated to the education. Thank you, Andrei. Thank you very, very much to be here. I was just telling Professor Cato to them that Dr. Kadri cannot be online here. He's traveling now.
Oh, okay.
He's coming back from the Brazilian Congress.
Okay.
It's happening now.
Okay.
But he sent him a video to recording lecture about the fourth ventricle. That will be very nice and very educate for the young generation.
Okay, thanks.
Thank you very, very much.
Thank you very much.
And Professor Baba, and I think we can start with your talk about the proximal.
Can you invite comments from Prof. Cato?
Yes, sure.
No, it's fine. It's okay. It's a short little time. But anyway, we are very honored to welcome Dr. Borba. He's a great teacher, and also he is a president-elect of the Water Federation. So maybe he can getting a very nice place for all of us. We expect you a lot. So thank you very much, and also the Brazilian and also the two Mexicans. Okay,
Thank you.
So please start your lecture.
Thank you, Professor Cato.
Thank you very much.
Thank you. I'm going to start one sentence. The mission of the World Federation is education, to bring all the knowledge to the world. And the world is like my back, is the real world. You cannot bring the division that you have today inside us. It will make the difference if you keep working together. I changed my topic to be related more to the young neurosurgeon. Education, training. The people say, how can I do? What can I do? Please help me. Please do something. Maybe your education is training. The first has to do something. is you. And your evolution will be up to you. Oh. I'm trying to advance. No, I cannot advance. Okay, good. This is my disclosure. Professor Al-Mafti is my mentor. I trained with him. I was in his lab during 3 years in Little Rock, Arkansas. I learned more than neurosurgery with him. I learned to be a doctor. I learned to behave as a doctor. I don't know, it's not moving. Harvey Cushion said many, many years ago, nothing is more gratifying to a neurosurgeon to remove a meningioma, for example, with neurological preservation. Maybe nothing is more gratified as a doctor, and not talk about approach, to get a patient 47 years old that come to you with tetraparesis in the wheelchair. You do the surgical procedure, remove the tumor, preserve the neurological structure, and this patient start to recover. And in few weeks or few months, he'll start to be back to his life. Maybe nothing is more gratifying to have a patient like this, a 34 years old guy that go hospital to hospital, doctor to doctor, come to you in wheelchair, tracheostomy, gastrostomy, and you do a surgery. We spend 18 hours in the OR, do microsurgery, and not talk about the approach again, but you see the plan, you can identify the neurological structure and the tumor that was impossible to remove. And the guy that had no hope, now he can go back. He back and continue his recovery and to try to live his life. This, not as a surgeon, but as a doctor, it's our mission. First, think in the patient. Second, think in the patient. Third, think in the patient. Time is time. 1996, I was returning from Little Rock, where I spent 3 years in the lab. It was difficult to get a job when I went back to Brazil, because the people are saying, oh, these guys had 3 years in the lab doing just microsurgery, doing cadaver surgery. How he can do surgery? What's the problem? Eat the blood, that's it. But with persistence and commitment, we did. Now 23, 24, this picture 23, when 96, I thought that I knew everything. Now I know that I don't know anything. And every day, I'm learning with you, with young generation, with every case, every patient that we see. Learning is a process that you can change and evolve every day. Today, there is no more time to train in the head of somebody. Today, there is no more time to train in the brain of somebody. Imagine if every pilot will train on flight. How many planes will crash a day? They train. After they go as a co-pilot, after many hours as a co-pilot, he can be the pilot. This make the difference, the persistence and the consistency. I'm seeing the people say, oh my God, I cannot do, I don't have good hands. I'm not like that other guy. I'm a young guy. I'll never be like that. Divine talent that given by God, you see in the football, few people has. Maybe Maradona, maybe Pelé, maybe not. Yes, Maradona, yes, Pelé. But focus you can get. Consistent you can get. If you see a video of Cristiano Ronaldo, this guy here, with 15 years old, you say, this guy will be a good player. But you never imagine how good he could be. Because if you have passion, if you have determination, you have focus what you do in the most difficult thing. If you have consistency in your entire life, you will be different. You will be completely different, and you can do a lot. This is my first temporal bone dissection. December 24, the night before Christmas, 1993. I remember in this dissection, I couldn't find the labyrinthine, I couldn't find the sigmoid signs, I couldn't find the facial nerve. It was difficult, but I didn't give up. I continued. And today, between surgery and course around the whole world, I have more than 1,000 temporal bone dissecting. But I'm learning in every course. I'm learning with every student, because the education and the learning is a process, as I said before. Neurosurgeon need to have an open mind. Neurosurgeon need to make a judgment. Neurosurgeon, you need to take risk. In your entire life, in any profession, if you don't have an open mind, you need to make the correct judgment. If you don't take risk, you never go anywhere. Maybe there is no other profession that you can leave in the morning smiling, you can come back crying. Because every neurosurgical procedure is a challenge. And every neurosurgery procedure, you need a lot of respect. And take risk. Life is take risk. Progress is take risk. In the literature, you can find the craziest thing that you can get. And sometimes has a new ideas, but does not mean that this new idea is the best idea they have in the world. You can find publications, you can find paper, you can find videos, you can find whatever you want. But you need to be judged. It's good, it's not good. This makes the difference. What means modern sometimes maybe not so modern, or maybe not so good. I don't understand so far why you change the idea to remove this tumor by transcranial with one procedure and do come from the nose and from the head. Change what is during many, many years is a gold standard. What's coming new does not mean that it's better. What's coming new is new. If it's new, you need to analyze. You don't need to change. Maybe you change, maybe not. Sometimes you can think and see what's wrong, what we are doing our entire life. We are taking a tumor like this, very large tumor in the meningioma. Why it comes from the nose? That you can know you can do a very beautiful procedure from the cranium and do a classical work that our teachers in the past taught us, and you can teach for the young generation that is coming. We need to understand that the best way to reach the brain, to reach the structure in intracranial, use the natural view. How you go to Veneza here, use the channels. And the channels of the brain are the systems. The system was given by God. You need to use all the system to reach the structure and expose all the structure. You don't need to say that you need to remove the bone in every situation, very aggressive. You need to remove the structure very aggressive in every case. Of course, in some cases you need, some cases you don't need. Depend of the pathology that you are doing. Don't do the approach that you know. Do the approach that the patient needs. This is very, very important when you do neurosurgery, and especially when you do medicine as a doctor. Do what the patient needs. You cannot do anything alone. Work alone is difficult. You cannot do everything is coming from your mind, and that's coming from somewhere. We need mentorship. We need people that as a whole model, the people that you trust, the people that you can follow. We need to sign to see the guy, see, this guy, I trust him, I follow him, not blindly, but have this important. We need to define priorities. If neurosurgery is not one of your priorities, change your job. Go to another job. This is very important. You can do what you think better. You cannot do anything alone. We need partnership. We need a guy that you can talk, you can discuss, that have new ideas. The controversy is good. The controversy open your mind. The controversy give you new ideas. The partnership, the mentorship, define priorities are crucial in your development. But the most important thing, be happy. If you do everything with happiness, your future will be extremely bright. Maybe not as a neurosurgeon, maybe not as a doctor, but be happy. It's good for you, it's good for the people that you treat. Today, the educational program is around the world. Today, the knowledge is universal. It depends just one person. You can do that. Today, you can see, you can watch lecture that you never imagined in your life. Today, you can watch, for example, you can watch a lecture of Professor Yoko Kato of 1 hour. Before was 10, 15, 20 minutes in a meeting. Now it's completely different. And everything is available to you. Depends just on you. You have online, on-site, hands-on, cadaver simulation, models, everything. You can do, you can train, the opportunities are there. Catch the opportunity, you make you completely different. The pandemic time was the worst time in our area. But for the neurosurgery, for the education, gave us a lot of opportunities. The webinar that we start in the beginning was changing life, changing the behavior, changing the knowledge of neurosurgery and the whole medicine around the world. Today you can travel, you can go and see. If you see the guy, they say, oh, this guy is very good. If you can go there to his place to see how he does in surgery, in real life, in real work, this will make the difference. Watch and see the people. You can learn 1 rose in each garden. You build your own garden with beautiful rose. This make you different. You need to plan neurosurgery. You cannot do like many people does in some public hospital. Arrive in the morning and say, what case I have to do? Well, which case is in the list? No idea how is the patient, no idea how is the pathology, plan in 3, 4, 5 minutes. Today, you cannot do that. We need to plan, we need to study to see what the best way to do the approach, to do the treatment. Sometimes the best approach is no approach. Doctor, first as doctor, first the patient. Neurosurgery, we need to deep understand of anatomy. We need surgical exposure. We need intraoperative monitoring. We need neuronavigation. We need technology. But the technology is not everything. The technology help you, but you don't know how to drive the technology, doesn't matter. The technology will help you, but your deep understanding of anatomy. Use the microsurgical technique. I call the X-ray view to know what's happening in the back is very, very important. Very, very important. And you can do that. Plan, study, and be prepared. We need to trust the people. We need to trust our boss, our teachers. We need to trust the people that has experience. Today, we are seeing a lot of people say, oh, I don't need to learn more temporal bone. I don't need more temporal bone approaches. I don't need Petroso approach. I don't need anything. I can do everything by a small roll near retrosigmoid. Professor Zhang from China, around 1,546 petroclival area meningioma. Around 50% he used the temporal bone approach. Anterior petroso, posterior petroso, or eat a little bit more bone. He has experience. We need to trust these people. These people has the experience. The white hair, the no hair, and this part is in occasion. This is because bring a lot of experience. Some good, some bad, but is experience. You cannot go to the meetings and learn and say and trust in everyone. You see the booth of Lexel Gamma Knife in the ACNS, the largest meeting in the world. This is the propaganda for Gamma Knife treatment. This is the best treatment for Gamma Knife? I'm sure that's not. And why they put this in the booth? I don't know. Maybe they are thinking in another thing, different than medicine, different than the patient. Sometimes they try to sell you. This is not the correct thing that you need, the correct thing that you know. Be careful. Be careful. Judgment and open mind is very important in any decision. Tumor like this, you can do a very simple procedure. The supracerebellar approach, you can go there and dissect and clean, and the bone that the tumor that the people was planning or suggest to send to radiation therapy, you can go there and remove this tumor safely as a ball, and this patient will be cured forever. This will make the difference if you know the technique and you think first in the patient, first in the patient and the best thing, not the machine that you have at home. Need the pre and the post-op of this case. The lab, the cadaver training is the best, is the gold standard. To do this kind of course is the gold standard. But the course is not to do the course Friday, Saturday, and Sunday, and come back in the morning, come back home, and Sunday and Monday morning, you do the case. It's to open your mind. You come back home with new ideas. You go to the anatomy department, you see more, you study more. After you feel prepared, you can do the surgery. Not be and do in the first case. Learn in the course and try in the patient. Don't do like that. Be prepared. Train more. After you feel very, very comfortable, go to the patient. But sometimes you go to the course, your goal is different. Like this guy here, see, he's sleeping all the time. This guy, maybe his certificate will be the biggest one in the wall. But he learned something. What's happened if his patients? He'll use the technique. He'll be fair. and honest with the patient? I don't know. Sometimes you blame the approach. Oh, this approach is not good. See this case here, maybe it's a little bit low, should be a little bit high, but this is a case, not my case, is a case. The problem is not the approach. The problem that the guy did a course in the weekend and came back in the on Monday and did surgery. Was not the approach the problem. The problem was the minimal knowledge and minimum training. Please, don't do that. Don't do that. Every anatomy department is a golden mine. This is the cadaver that you see around the world. In every anatomy department, in every medical school, you have a cadaver like this. They are not smelling good, they are not so nice in color, but the anatomy is the same. This is the cadaver that we do it for the picture, for training, for education. But this cadaver is to save lives. You go there in the anatomy department and train. If you learn a new approach in the course, go to the anatomy department in the other week and train and try to do. After you go to surgery, you can do, you are doing to save lives. This is very, very important. Today, the education and training you can do in everywhere. You don't need to be in the anatomy department, don't need to be in the hospital, you don't need to be in the operation room. You can do in everywhere. You can do in your home. You can do in your place. This, for example, this upsurgeon is very nice. Is the best model? No, of course not. But it's very nice idea. You learn how to use the instrument. You learn how to use the microscope. You know how to find your hands. That sometimes is very difficult when you are doing in surgery. These training models give you this perception. Training in everywhere. Training every time. Training always. The model give you this opportunity. There is a very cheap model that we are using here in Brazil with placenta. You connect to a small pump, very small pump. This pump is connected, is one artery, another artery. You take the placenta, put inside the 3D model cranium. You simulate the Sylvian fissure, and you can dissect as a microsurgery. At the end, you can take one artery here, superficial, and do the microanastomosis. The placenta is free. The placenta is the best model to the microsurgery. It's perfect, and is 100% free. The instruments that you can get, you can buy in the jewelry. The guy that fixes watch is using the same instrument that you are using the microsurgery. You can go to anywhere. You go on the street. You can buy by $1, $2, $3 this small forceps, small scissors, small thing that you can do. Just if you want, you can do it. But more important than that, the facility that you give, it's our lab in Brazil, okay? It can give you the best facility. You can have the best facility, but you make the facility, it's not the facility, it's you. You believe that will be the same? Look, this wonderful lab. What is missing here? The people is trained to train. Where are the residents? Where are the medical students? Where are the neurosurgeons? Why nobody is training? You believe that this guy here that is training every day, he leaves the OR, he go to the weekends, Saturday nights, Sunday, he go there to train. This guy will be the same like the other guy that never trained? Of course not. He dedicated himself. He go there with commitment, focus, determination, and consistency. he will be different. And you can be different. You never, maybe few of you will be Pelé, will be Maradona, but you can be Cristiano Ronaldo, that the guy that train, and dedicate himself. You need to study. You need to take the book, to study, read again, see the videos, and you need to do that. This make you different and improve every day. You don't learn everything on the first day. You don't learn everything in the first read. Sometimes you need to read and read again and read again to have the thing. I'm saying from the sky just come rain, some stone, and now, unfortunately, bombs. But you can do by yourself. You need to do what you like it. You need to do what you love it. It must be your priority. Neurosurgery must be your priority. You need to be strong what you do. You need to be your consistent. The neurosurgeon can make you cry one day, but the glory and the passion that every day you give him will make you better every single day. Thank you very much for you, and thank you for the opportunity. I hope this lecture gives to the young generation a bright way that we need to do neurosurgery with focus, determination, consistency, and especially passion. Thank you very much for you. Thank you very much.
Thank you so much, Professor Baba. It's indeed a very insightful and exciting, enthusiastic lectures to the young neurosurgeon, and it really deep and really I will really echo with your message. So maybe shall I invite comments from Professor Cato? Professor Cato also.
Thank you so much, Borba.
Thank
It's
you.
a wonderful talk. So because maybe that you keep the for a long time the motivation and also the passion for the study and education. It's very important, I think. So keep for a long time is sometimes difficult, but you did and you do so every day. I learn a lot. Thanks so much.
Thank you very much, Professor Casso. You are trying to follow your steps.
Okay,
What you
thanks.
did, you're still doing to the area. You are our mentor. We are following you. And please help me to continue in this and bring more
Yeah, of
this
course,
young
yes, we
generation
all
from
help you.
Asia. This
course,
young
we all
generation
help
from
you.
Asia
Yes,
make the
yes.
difference.
Yeah, please teach the Kyrgyzstan. Kyrgyzstan is one of the developing country, I think. Please
Yeah,
teach them.
I'm here, these young people here.
Yes,
They're
I
very
know.
bright, they're very nice.
Thanks a lot.
Very good food.
Really? Okay. Right.
Okay.
Maybe my colleague Nazman.
Yeah, thank you, Professor. Can you hear me, please?
Yeah, you
Yes.
can hear.
Okay, me, Dr. Nazmin Ahmed, a neurosurgeon from Bangladesh. Now I am doing my fellowship under Professor Iko Kato in Fujita Health University, Bantana Hospital. So heartfelt thanks to you because of your nice lecture on, you have very nicely explained the importance of laboratory work and cadaveric dissection to be a good surgeon, to be a deal with skull-based surgery. So my question to you is that, as because we belong to a resource-limited setting, because I am a neurosurgeon from Bangladesh, and after doing my fellowship here, Professor Kato have beautifully arranged bypass surgery practice here under her guidance. So my question to you is that is there any facilities for a lower to middle income countries young neurosurgeons to your facility, or whether you can provide any short-term visit or training facilities to your institution?
Our institution is open 24 hours, 7 days, 365 days a year. You are very welcome, very welcome anytime. The problem today is not this, the facility. The problem sometimes is to get scholarship.
Yes. I agree. I
This is,
definitely agree.
I'm saying, Professor Cato, we need to leave this mess that is going on and concentrate on it. Concentrate in the future. This will make the difference. It's open. I have a lot of places around the world, not only in Brazil, in the whole Latin America, in Asia, in Europe. You see the facility, but you will make the difference. You in Bangladesh can make the difference. When you come back to your country, you train somebody, you help somebody, and you multiplicate your knowledge. This is most important thing. What I'm seeing sometimes, the people wants to go to another place. Oh, it's very nice in Japan, one of the best places in the world, maybe the best place in the world. I want to stay here. No, come back to your people. Go help your people. Train somebody. Go there. Your developer will help you. If you will come to train and stay and not multiplicate your knowledge, doesn't matter. It will be a trouble. See, you will be one of the vertex of this development. You have a great mission. Come back to Bangladesh and train the people and help the people. This is make the difference. When Professor Cato, 1,000 people of neurosurgeons and young neurosurgeons that she trained, she was thinking like that. She was not thinking to take 1,000 new neurosurgeons to Japan. She was trying to do 1,000 neurosurgeons around the world. This is make the difference. Okay, I'm talking too much here. I'm like a priest now.
Okay.
Thank you so much.
Okay, go ahead. Let's continue.
Thanks. Okay, please. Dr. Ben?
Yes, and
Shall we continue? Thank you very
yes,
much for Borba.
yes, and just first of all, I want to ask if any comment from the floor. If not, can I make a short comment? I personally learned so much from the Borba, and not only the knowledge, but the passion and the spirit that you chase neurosurgery. So I agree that we not only focus going to one particular cadaver course or one particular topic of dissection, but we need to go to many courses of dissection. My spirit is that I really think seeing different people, how they approach the same dissection will be very useful for me to learn from different experts. So that I could learn a lot from different cadaveric courses on, let's say, on the same topic, like temporal bone dissection or endoscopic neurosurgery. Every time you learn something. And I agree that daily practicing with your lab is very important. I'm still applying this knowledge and try to do it every day with either training or, for example, the bypass or other things. And I have a last question. In your because we're also having a laboratory only, so I'd like to ask about how would you handle the placenta? So is there any ethical? Do you use human placenta? Is there any ethical issue for you, and or how to prepare for yeah?
You can use the human placenta and you can use the bovine placenta. Okay. After sending me a WhatsApp, I give the direction of the guy that organized everything. He can help you step by step how to do it. See?
Sure.
How to do it, how to prepare everything. It's very simple. But it's very important today to have the license from the patient, from the mother, or somebody that you need the license to be approved. See?
Thanks.
It'll be good. It'll be good.
Yes.
Thank you.
Okay. So much. So are there any questions from the floor? If not, shall we proceed to our next webinar from Professor Kadri? And
let's do something. May I suggest to you? Dr.
Yeah.
Andrei is in the meeting. Maybe he has some lecture now
Oh, yeah.
in the morning. May we start with him, Dr. Andrei, and after that, Dr.
Okay.
Juan,
Sure,
and
yeah.
Kadri will be. Kadri is just leaving the airport. Maybe he can enter by phone. Okay.
He is here. He is here.
Sure.
If Andrei Joaquim can be, may I
Hello.
introduce him?
Yes,
Yeah,
please,
yeah.
please, go ahead.
Please.
Please, please.
Let me tell you one thing for the young generation here.
Yes.
Do you know who trained Dr. Andrei Joaquim? To have some idea, Dr. Andrei Joaquim was trained by Evandro de Oliveira. You know Evandro de Oliveira?
Yes.
One of the brightest neurosurgeon, microsurgery in the history of neurosurgery. Dr. Evandro de Oliveira, he was always say the words that I said. Do what you love it, what you like it, and do what will make you happy. And when Andrei said to Dr. Evandro, I will do spine, Dr. Evandro almost had a heart attack. But he said to him, Andrei, if you love it, if you really enjoy to do this kind of procedure, do it, but do the best way that you can. This is Andrei today. Today is a neurosurgeon that is totally dedicated to the spinal surgery. He has all the medical degrees that you can get, a lot of publication, but he does his spine with the heart. It makes him different. He's different. He's different. You see him now. Thank you very much, Andrei, for your time. I know that you are in the meeting there. Maybe you are in the room. Maybe the connection is not so okay. But thank you. Please go ahead.
Well, thank you for your kindly words. I really miss Evandro, and it makes me feel sentimental about this. Thank you for this opportunity to be here, and I will give you a presentation. It's a little bit different about craniocervical junction. I'm sharing my screen. Please let me know if you can see my screen.
Yes, you can.
Thank you for putting me now in the presentation, because I have another presentations here in the meeting. Well, I'm going to talk about craniocervical spine trauma. I am, as Dr. Borba said, I am a neurosurgeon, but I only do spine. I work in Campinas and São Paulo, and I am the head of the neurosurgery division of the University of Campinas. When we talk about spinal trauma, we share the spine according to the same characteristic of each region. For instance, we share the occipital-cervical junction from subaxial cervical spine because they have similar characteristics, biomechanical characteristics. And from this presentation, I'm going to focus on occipital-cervical trauma. Do we have to operate it early, the patients? Yes, we have. Why? Because early surgery makes you rehabilitate these patients better than with late surgery. We avoid a lot of complications, and also there is some evidence about neurological improvement. But we need to have a stable patient and expert surgeon available, as well as human and material resource to do an early surgery in the acute scenario of a spinal trauma. This is a study, the Stasis 2012, that they prove that early surgery before 24 hours can improve the neurological outcome of spinal trauma. This patient was operated 3 hours after he had this injury, and he's able to walk. So specifically, when we talk about craniocervical injuries, there is an anatomical complexity because each vertebrate is unique. There is a cranial-based relationship, and the ligamentous stability is the most important factor that we have to evaluate it when we see a craniocervical injury. Just to make sure that all you know, the craniocervical junction is the most mobile spinal segment. About 50% of the flexion and extension, it's in the occipital C1 joint, and the rotation is at the C1, C2 joint. When I'm going to talk about the new AO spine, for those who doesn't know, the AO spine, don't know, the AO spine is an international society of spinal surgeons, and we are involved in this classification about the upper cervical spine. These studies is to show that it's not only a proposal, but it's a scientific classification with methodological basis. And how does this classification works? We divided the segments in occipital condyle and craniocervical junction, C1 and C2, C2, C2 and C2-3. And so we segment the craniocervical spine, and we share the injuries in type A and type C. Type A are those with minor or only bone injury. Type C are those we have clear displacement and they are clearly unstable. And type B is for those which we have a suspected or a clear ligamentous injury, but without displacement. This is the most difficult classification is for type B. We also use the modifiers of the neurological status and the modifiers of injury itself. I'm going to show you how does it work. Here I'm going to talk about condyle, occipital condyle. So type A are those isolated condyle fractures. Type B are that you have avulsion of the condyle or ligamentous injury without displacement. And type C are atlanto-occipital dislocations. C1, these type A are Jefferson fractures. Type B are transversus ligament injuries with or without Jefferson fractures. And for type C are atlanto-axial dislocations. And when you go to C2, C2-3, type A includes odontoid fractures and Hangman's fractures without important dislocation. Type B are those Hangman with some ligamentous injury, and type C, severe displaced injuries. This system is validated and accurate. What it means that if you apply in Europe, in the United States, or in Brazil, we have very similar results. So it's important when you validate the classification that you can reproduce it elsewhere. Here are some case examples of mine. A condyle injury type A, conservative treatment. A type B, you have avulsion of the ligament. This can be potentially unstable, but it's not in this case. And type C, in this case, you have a clear occipital C1, C2 dislocation. This patient would be referred for surgical treatment. This is a type C, a child we operated. You can see clearly that he has ligamentous injury in the occipital condyle C1, C2 joint, an hematoma in the upper craniocervical spine, and we perform an occipital C1, C2 fusion, and he did pretty well. It was a boy. When you go to the C1 vertebrae, we have the Jefferson fractures that are the most common. You can have Jefferson with posterior arch fractures, anterior arch fractures. And when you have type B, you have a suspect ligamentous injury. And you can see here, you can have an avulsion of the ligamentous or a rupture itself. Sometimes the MRI is pretty important in such case. And it's important because you can look at this fracture. I treat him conservatively, non-operative with a brace. He did pretty well. And this one, you have a very displaced C1 from the other C1, and we did a C1 fixation, restoring the C1 ring and without occipital C2 fixation. When you go to the 2C injuries, what is 2C? C, remember, dislocation. You have this case like this, a very C1, C2 dislocation, a rotatory traumatic C1, C2 dislocation that we fix it with C1, C2 fixation. Going for C2 is the most controversial because you have odontoid fractures. Odontoid fractures, most of the odontoid fractures, they have a right risk for pseudoarthrosis, but they are type E, not type B. For type 3B, for type B injuries, we include Rangman without dislocations. You can see here, you have a posterior elements of the axis fractures without dislocation. This patient can be safely treated with a brace without surgery. And for type C, we have a C2-3 dislocation. This is very unstable and requires C2-3 stabilization. This classification include the knowledge of all the previous system, the Trinellis, Anderson, Montezano, Jefferson, Levine, Wilder, Dickman, Anderson, and Alonso classification. What does it mean? Is that we get all the information from the previous literature and put it together in a hierarchic crescent degree of severity, type A, B, C. And it's reliable and validated. Most of the recent studies are based on this classification. I have another proposal that it's not against the AO, but it's simple and it's useful in practice, in your daily practice. It's based on instability, ligamentous injury, and characteristics of bone fractures. This was published before the AO study, and I believe that most of the AO study was based on this. It was published and validated. We publish our series, we publish our proposal. How does it work? When you have an occipital C1, C2 joint, you see if there is some dislocation. If you have some dislocation, it's surgical treatment. And depends on the dislocation, is the segment you have to fuse. If you have occipital C1, you fuse occipital C1, C2. If you have atlantoaxial, you fuse a C1, C2. If you have instability C2-3, fuse C2-3. If you don't have dislocation, then you have to look into the fracture itself. Almost all fractures in the occipital C1, C2 joints can be trial in patients neurologically intact, can have a trial of a cervical collar and brace without surgery, with the exception of odontoid fractures. Odontoid fractures are the most unstable, and if you have criteria for non-consolidation, you can consider early surgery. So how do we evaluate ligamentous injury? With misalignment, locked facet joints. If you have an increased atlantodental interval, it suggests that the transverse ligament is injury, dynamic instability, and the MRI. The MRI, you have to be cautious because MRI is very sensitive. Sometimes you don't have dislocation, but you have change in MRI, you have considered case by case. This is the type B from nail spine. Some case example, take a look at this. We have bilateral avulsion of the condyles, C1, C2 distraction. Then we have to do occipital C2 fusion to stabilize the ligamentous injury. This is another case, you have a displaced C1 lateral mass. It's unstable because it's displaced. You have to do an occipital cervical fusion. Another case, you have dynamic, this patient has severe cervical pain after trauma and have a dynamic subluxation of C1, C2, C1, C2 stabilization. This patient, it's clearly unstable. We have odontoid fractures with neurological deficit, with C1, C2 dislocation. We did a C1, C2 fusion with reducing and stabilization. Clearly unstable surgical treatment. And when you don't have stability, you look into the fracture itself. This is a young guy with a odontoid fracture. You can treat this with a cervical brace, or you can put an odontoid screw, because the odontoid fracture type 2 there's a right risk of pseudoarthrosis. So you can manage it surgically or try a brace. This is another fracture, a type 2 odontoid, but it's in a 91-year-old lady. So we have very right risks for pseudoarthrosis. Surgical treatment is recommended. In conclusion, when you evaluated craniocervical junction fractures, you have to look at the ligamentous and spinal alignment. If you have a very spinal aligned and no neurological deficit, most of these fractures are stable. And when you have bone injuries, almost all bone injuries, with some exceptions, can be treated with a cervical brace, with the exception of an odontoid fracture. Thank you very much for this opportunity. It's a great honor to be here with you today.
Thank you so much, Professor Andrei. And I can indeed see so much effort that you put into your spinal surgery practice, and it's just one of the tip of the iceberg that you do. And thank you so much in this for sharing this session. So, are there any questions from the floor concerning the Professor Andrei's presentation?
So, Andrei, thank you very much. So, even a very hectic time schedule. So, we learned a lot from your lectures. So, in Japan, of course, as a neurosurgeon, we do of course, the spinal lesion, but maybe I think less than 50%. So, just you can encourage, how you can encourage the Japanese the neurosurgeon to do the spinal lesion.
What I would say, from the general perspective, all neurosurgeons do a little bit of spine, at least in small cities or medium cities. But I believe that in big cities, we should dedicate it only to spine. As Dr. Borba said, it requires some expertise, and the cases are not the same. And I would recommend it to young neurosurgeons, if they like spine, they focus on spine, follow their passion, and dedicate. It's difficult to do everything today. It's very difficult to be a vascular neurosurgeon and you do children. It's not impossible, I know, but I would suggest that we have to be a specialist, dedicated in subspecialties. And Dr. Borba gave the lesson: follow a master, someone that you trust, not blindly, but follow it. See other guys, goes to other hospitals, because sometimes you follow someone that it's not open mind, and you have to see a lot of surgeons, and dedicated to spine surgery is really nice. It's like Dr. Borba said, a passion.
Thank you very much. So I think it's very interesting in the spinal lesion study, I think. What about the endoscopic procedure? Because you focus on the trauma case so many.
Endoscopic for degenerative?
Yes.
What I think endoscopy in Brazil it's getting stronger, but I believe that the indication should be the same. What I am seeing, I am a microsurgeon. My boss was a microsurgeon. I like endoscopic for some disc herniations, but I think that sometimes the endoscopic are pushing too much in spine, doing, for example, doing spinal schwannomas with endoscopy. They push the tumor. It's terrible. I believe that endoscopy, there is a role. It's important, but won't substitute microsurgery. It helps microsurgery, and the indications should be the same. It's not because you have a 1 centimeter incision instead of a 3 centimeter incision that you can change your indication for surgery. And that's my personal bias against endoscopic, because sometimes you don't have even a disc herniation and people are doing an endoscopic. This is not correct. It's my opinion, personal opinion about this, Professor.
Oh, okay, you're right. Borba, any comments?
Yeah, brilliant as always, Andrei.
Thank you, Professor.
Today is the new technology, new approach, and I think it's coming to the spine in improving a lot. And the neurosurgeons are day by day more involved in spine. I think spine is a business for also for a neurosurgery, but do the correct way, the perfect way. I think in Latin America, in the whole world, maybe in Asia a little bit less, the neurosurgeon is doing more than 50% doing spine. I do 0.1%, very few cases. But if you do and dedicate yourself, I think it would be great. Congratulations, Andrei.
Yeah,
Good
Thank you,
as always.
Professor. Thank you very much.
Nasman?
Uh,
Nasmi?
Yes.
Last
Thank
question.
you, Professor. Can you hear me?
Yes, perfectly.
Yes. Me, Dr. Nazmin Ahmed. I have already given my identity. I'm a neurosurgeon from Bangladesh, a young neurosurgeon. So surgery at the craniovertebral junction always difficult. And from your lecture, I have noticed one thing, that you have mentioned a very important point. Whatever there is involvement of 3-column or 2-column of the spine, preoperative evaluation is very important, and we should have always to look at the natural sagittal balance, that is the normal curvature, the extent of distortion of normal curvature. So before going for a operative explanation, preoperative evaluation, especially in the craniovertebral junction, bears the utmost importance. And that whether we should go for conservative management, whether we should go for operative management, and lack of knowledge, proper knowledge, always leads to inadvertent surgery. What I have observed in my country, that sometimes there are some inadvertent exploration, inadvertent surgery, whether the patient might have achieved improvement after conservative management. So this is my comment. And I have one question to you, that if you decide for conservative management, say for example in C1 fracture, so what kind of brace you have used
Okay.
in your facilities?
Very good question. I would tell you, if you have to put a halo on me, I would prefer that someone operated me. Halo, it's severely stressful and it's terrible. If you have a psychological test in people with halo, it's similar to you have a cancer, a terminal cancer. And so I use a hard cervical collar. I do believe that these patients with non-operative injuries, they get healed the injury, not because the cervical collar, because they heal. And so I don't see any reason to put a halo. If you go to the AO site, they put halo for type B injuries. I don't agree with that. In my humble opinion, if you are suspecting that this injury is unstable, you should follow this patient, come back next week with a cervical x-ray, and if it's doing bad, if there is worsening misalignment, clinical signs of cervical pain, important cervical pain, then you should go and fixate these patients. And if you do selective fixations, they do really well. And halo, it's 2-3 months with halo, with pins, you go to your house and the grandmothers get to the grandchild with that. It's terrible. So I won't recommend a halo. I would recommend a hard cervical collar and close clinical follow-up.
Thank you very much. So the short question, Ben.
Yeah, and maybe I leave the chance to Jeremy. Jeremy, you have a question?
Thank you, Ben. Thank you, Professor Joaquim, for the wonderful lecture. My question concerning the spine, most of the time when you fix the spine with the instruments, you get loss of cervical motion, either as rotation or flexion. I don't know what your experience has been with the patients after you've operated and fixed them. Do you routinely remove the implants after the fusion has occurred, or do you leave them permanently on the patient?
Most of the times I leave the implants, but there is some circumstance you can remove the implants. And for example, if you have a C1 lateral mass fracture that rotates the neck, and we can try to do occipital C2 and remove the implants. I have done this in selected cases, but it's very rare. Generally, I put implants and follow them in the outpatient clinics, and goodbye when it's healed. I don't use to remove the implants because it's another surgery. I agree with you. That's why we should avoid occipital cervical fusion in older patients, because older patients, they need flexion extension to basic daily activities, like to put shoes, put socks, like to put clothes, to dry clothes. So occipital cervical fusion, it's more morbidity in older patients, but I don't use to remove it.
Thanks so much. So Ben?
Yes, thank you so much. And so for the sake of time, so shall we move on the next lecture? But just a last comment, and I really thank you so much for joining us today and with your busy schedule today. And we also pay a big tribute to Professor Ovendo de Rivera. So I personally also learned from him in the previous courses, and we really miss him very much. And Professor Barbara, shall we move to next speakers?
Yeah.
Yeah.
Okay.
I will say
Okay.
goodbye. Thank you very much.
Thank you,
A great
Andre.
honor.
Thank you.
Thank you,
Okay.
Professor Borba,
Thank you
again.
so much.
Thank
All
you.
the
Great
best.
honor
See
to
you
be
again.
here. Bye-bye.
Thank you.
Thank you.
Bye.
Bye-bye. Thank you. Our next speaker doesn't need introduction. Juan-Luis Gomez Amador was the chairman, skull-base center of the National Institute of Mexico. The National Institute of Mexico is the largest neurosurgical institute in whole Latin America. Professor Juan Luis trained in Mexico. After he moved to US, to Little Rock, Arkansas, with Professor Yashagil, and spent many, many years there. Well, 1 year and a half, 2 years and a half, I don't remember, in Little Rock, of Arkansas. He's a brilliant microsurgeon. He's a very bright and intelligent man, and very honest man. And he shows his experience. He has a lot of case. And he's the guy that you say he's learning every day, and he's teaching every day. Today, Juan Luis has a school around Latin America. I think in every country in Latin America, there is one guy that is training by Juan Luis. Juan Luis, thank you very much, not for your teaching, not only for this, but for everything that you did to the young generation in Latin America. And keep doing, please, and help me. Okay, please go ahead, Juan.
Yeah, thank you very much, Professor Borba. It is an honor for me to be here with all of you, to give this that we can consider a controversial talk. I want to thank Professor Yokokato, Dr. Ben, and obviously Professor Borba for the invitation for this great webinar. What does the patient need from surgery? He expects improvement of the symptoms of their disease. We must provide the appropriate diagnosis. We need to improve prognosis also, but always trying to preserve neurological function. To do that, we need to know that the foundations for a safe surgical procedure consist, among other things, in an appropriate tridimensional anatomical knowledge, stereoscopic vision, tactile vision, as we will see later, also to perform all the maneuvers with common sense and courage. To have an example of this, I present you these three cases, all of them cavernomas. The first one located in the thalamomesencephalic region. We perform a left diurnal, transilvian, transinsular, transchoroidal fissure approach. And this seems to be complex, but this is an appropriate approach, targeting the lesion and trying to perform a precise lesionectomy, as you can see in the postoperative MRI. For other cases, most conventional approaches as this left occipital posterior interhemispheric paraspinal approach to treat this lesion located on the thalamus also, or a median superior suboccipital approach with a supracerebellar approach to treat this pontine lesion. So, as you already hear, we need to have the joy and passion for neurosurgery. And I think Borba is a good example of what we learn in Little Rock. He is the predilect student from Professor Almefti, and he has teach us that going to the laboratory and have this experience of improving the technique, and we are following his example. He's author of many publications, many webinars, but most importantly, he's a devoted teacher that gives us the tools that we are following in Latin America. In Mexico, for example, we have a splendid laboratory in the National Institute of Neurology and Neurosurgery, and there are some other institutions now growing to give the neurosurgeon to be, or the neurosurgeon with the expertise, the opportunity to perform laboratory dissection, and in that way, we can improve the results for our patients. In one of these meetings, I was talking with Professor Almefti, and we came to the conclusion that endoscopy is a tactile surgery because we use both hands in the surgical field, and through the proprioception, we can replace the lack of three-dimensionality that gives us the microscope. And for this instance, we have three specific scenarios in which we can use endoscopic techniques. The first one, the endoscope-assisted microneurosurgery that we can use to treat intrinsic and extrinsic lesions, intraventricular lesions, and also aneurysms. The endoscopic port surgery, in which we navigate inside the brain to treat intrinsic lesions, metastases, intraventricular lesions, and as we will see, aneurysms and cavernoma. Finally, the endoscopic endonasal surgery came to us using a natural corridor. This is the nose to reach lesions in the base of the skull. So most of the patients that we treat with these techniques belong to the patients that have pituitary adenoma, some of them chordoma, cranopharyngioma, meningioma with a lot of controversy worldwide, and we can use these also to treat aneurysms and cavernoma. If we see the first scenario, I will present you with this patient with multiple intracranial aneurysms, ruptured right MCA aneurysm, and some other aneurysms incidental in the same setting. So we perform a unilateral approach coming from the right side and splitting the left sylvian fissure to reach the contralateral MCA aneurysm. Here we perform a standard diurnal with clinodectomy, wide dissection of the basal cisterns. We reach the contralateral sylvian fissure. We treat the contralateral MCA aneurysm. So at this moment, we introduce the endoscope to see that the blades of the clip are not obstructing or conditioning some injury to the patient. Then we came to the anterior communicating artery aneurysm. We performed the clip under microscopic vision, and then we introduced the endoscope to achieve a complete visualization. Then we came to the ipsilateral side. We did a PCOM aneurysm and other MCA aneurysm. So in this way, the endoscope gives us a vision that helps us to achieve a complete and integral visualization of the perianeurysmatic anatomy. For the use of endoscopic ports, we have treated many lesions inside the brain parenchyma. But for the meanings of this talk, we need to understand, after Paulo Kadri's and Professor Ture's studies on the brain anatomy, we learned that the full understanding of the fiber tracts inside the brain parenchyma are essential to be known in order to perform an adequate positioning of the trajectory that we are going to follow in a certain case. I present to you this very rare case of a patient with a subarachnoid hemorrhage, and a parenchymal hemorrhage erupting the ventricle due to a rupture of the P3, P4, PCA aneurysm. So in this case, we choose the endoport technique to perform the procedure. So we put the endoport, and then we perform the evacuation of a parenchymal and intraventricular hemorrhage using navigated endoport. We were able to perform vascular exploration, clipping of the aneurysm, and performing an aneurysmectomy with the endoport. And as you can see here in the postoperative CTA, this was adequate for this patient without injuring the surrounding tissue or vessels. For the endoscopic endonasal surgery, we need to understand that there are different levels of difficulty to perform these approaches. Most of the times we go to the sella turcica to treat pituitary adenoma, craniopharyngioma, etc. But we have a wide variety of variations that can take us to different compartments in the skull base. And also, but for very specific lesions, we can treat aneurysms using this endoscopic endonasal technique, or we can perform also the treatment of intrinsic lesions located on the brainstem, such as cavernoma, metastasis, or gliomas. To do that, we need to be aware of the potential complications that are related to endoscopic endonasal surgery. The most important and most criticized complication is the CSF fistula. And in order to deal with that, we need to have a proper and standardized protocol for the reconstruction of the defect that we are leaving after we finish the procedure. Also, it is very important to have technological accessories such as the endosuite, navigation when needed, interpretive monitoring or stimulation of the nerves, particularly when we are coming to the mid-clivus. We need to have also Doppler ultrasound to inspect the anatomy of the internal carotid artery or other arteries related to the pathology. And most of the times we perform the procedure under a 0-degree endoscope. But for some instances, we can use also a 30-degree endoscope to have a direct visualization of the lateral portions, for example, where we are dealing with lesions in the cavernous sinus or the mid-clival region in order to assess the anatomy of the sixth nerve. Saying that, we can use the natural corridor of the nose to reach through a superior transclavian approach, the middle transclavian approach, or the inferior transclavian approach to treat lesions located in the subarachnoid space, but also to treat intrinsic lesions such as the brainstem. Here we have a very nice view with a middle transclavian approach in which we can see the basilar artery and the ventral surface of the pons. So if we take out the clivus that is in front, treating properly the venous channels in the dura mater of the clivus, we are able to perform an adequate explosion and a direct access to a lesion located in this area. This should be reserved for very specific cases. So for example, in this case, we can see that the anatomy of this lesion located in the ventral pons can be approached to a direct transclavian approach. Particularly, it's very important to have a MRI tractography in order to assess the position of the long tract fibers so we can avoid damage to them. So I present to you this case. This is a patient of 29 years old who came hemiplegic with severe dysfunction of the cranial nerves. So we put him under tracheostomy and gastrostomy and give nutrition for 3 weeks. When his conditions improved, we decided to perform an extended endonasal approach through a middle transclavian approach to perform access to the direct access to this lesion. So after performing the clivectomy, we found the entry point. We evacuate the hematoma associated with the cavernoma, and after careful dissection, we were able to take out the active portion of the cavernoma. Look that we are just working aside the basilar artery, and we are trying to perform complete excision of the lesion, as you can see here. After finishing, we can perform inspection of the surgical field and performing hemostasis and careful reconstruction in order to achieve a good result, as we can see here. This is the patient in the postoperative period with the tracheostomy. It turned out to be a cavernoma, and you can see in the postoperative MRI complete excision of the lesion through a very direct approach that is just suitable for this patient, but maybe is not the best approach for other patients with different locations. After 6 months, the patient was able to walk again, but he didn't recover the force in the arm that he had previously in the preparative period. We present another case. This is a male of 65 years old with bilateral pyramidal syndrome and six cranial nerve palsy. We tried to come to this lesion and perform a subtotal excision of the lesion. The patient had extensive studies showing no systemic disease, but we considered that the compression of the brainstem should be the first step in order to obtain diagnosis and also to have improvement of the patient. In the postoperative histopathological result, it came to be metastasis, so we sent the patient to neuro-oncology and they treated as well. So this is another example in which the transclavial approach gives us straight access to the pons in the ventral region. This is another patient, a female of 27 years old, who presented with acute headache and left hemiparesis and left hemianesthesia. As you can see here, the location of the lesion is facing forward the ventral surface of the pons. So the natural corridor of the nose through a transclavial approach gives us direct approach to this lesion. So we choose this corridor after performing a proper clivectomy, opening the dura mater, dealing with the venous sinuses with the bipolar coagulation and surgical foam. We identify the entry point, as in the similar case before. Just aside the basilar artery, we evacuate the hematoma, and with careful dissection, we are able to perform the extraction of the active part of the cavernoma. So, why do we do this? Because this corridor was just straightforward to the lesion. We don't need to cross the nerves, and we perform the precise lesionectomy without damaging the surrounding brainstem tissue. Careful reconstruction with dural substitutes and the placement of a pedicle nasoseptal flap allows us to avoid the CSF fistula that can complicate even up to 30% of the cases reported in the literature. So you can see here the patient in the 5th day post procedure, she's intact in the cranial nerves. After 2 months, she was able to perform her normal daily life. And in the postoperative MRI, you can see the precise lesionectomy that we perform. So in this particular case, we were able to take out the lesion without producing damage to the patient, with no crossing through the nerves, and performing precise lesionectomy. But this should be reserved for very specific cases. And the aim of this lecture is not to present these cases just by the interesting neuroanatomical and surgical characteristics, but because after many years of performing these endoscopic and endonasal approaches, we can see when a selected patient is able to be treated with this endoscopic and endonasal approach, but for some other patients, as you can see here in this series, of 751 cases, only 8 cases were treated with endoscopic and endonasal approach to treat a lesion like this. So this means that we need to be very selective in the cases so we can perform adequate approach. So the transclavial approaches gives us a direct surgical corridor for certain pathologies located on the skull base, but also in the interpeduncular, prepontine, and prevulvar systems that can be easily accessed through these approaches. The treatment for intrinsic lesions located in the brainstem using these techniques should be reserved for very, very selected cases. and it is obvious that the experience of the surgical team and a careful analysis of the case must be addressed to use these techniques. I thank you very much for the opportunity, and I remain open for any question that may occur. Thank you.
Thank you, Juan. Wonderful.
Thank you, sir.
You know, new ideas.
Yes.
Does not mean that you today is Saturday, yeah? Does not mean that the case Monday has to be by transnasal. New idea that's coming. These neurosurgeons have the open mind. See, open mind, new idea coming. Professor Juan Luis has a lot of experience in microsurgery from the head, microsurgery from the nose, microsurgery from the side. But it's new idea that is coming. You see, the future, you say that you are right or are not right. But the ideas like that, the idea is coming. I don't know if somebody heard. Nan, go ahead, Nan.
Yes, thank you, sir. Thank you for your lecture. It's in this thing the extended application for the translational surgery, and in this is very impressive to do the transcatheter approach. Just a few questions I would like to ask about. So what is you mentioned about your protocol of the skull-base repair or CSF leak. So what is your protocol for using it? And when you're doing transcatheter approach, how would you harvest enough length of the nasal septal flap to cover the defect? My second question is about, do you use the endoscopic holder or you ask your assistants to hold the endoscope? Because doing the angle wheel with the transcatheter also sometimes very difficult for if the assistant is not very familiar with it, and it sometimes will collide with your instruments. And yes, I think these are the two questions that I have with you. Thank you so much.
Okay, thank you for the question, Professor Ben. We don't use an endoscopic holder for the surgery. The endoscopic endonasal surgery is a two surgeons surgery. So we need to know each other very well, so the maneuvers can perform in an ergonomic fashion. So usually there is no collision of the instruments, because for some instances, the endoscope usually goes above the instruments, so the instruments come behind the endoscope. And for very specific parts of the procedure, we invert this relationship. So we put the endoscope in the bottom and the instruments above. So in that way, we are able to deal with different aspects of the lesion. For the surgical protocol of closure in transclavial approaches, we use dural substitute inside the dura mater. Then we put the fascia lata above the dura mater, and then we stick that with a small piece of bone gained from the posterior septectomy. And after that, we put a nasoseptal flap. How can we do to reach a large nasoseptal flap? We took not only the septal flap, but also we take the mucosa from the floor of the nose. And in that way, we extend the length of the pedicle graft, and it is enough to cover the defect. For some other lesions, for example, extensive chordomas that involve the anterior cranial fossa, the nose, the clivus, usually we can perform the nasoseptal flap, but in some cases there is no mucosa in the nose, so we perform pedicle pericranial flap, and we perform a small hole in the glabella. So we introduce the pericranium to the nose so we can cover all the defects. After this, we put some sealant in front of all the reconstruction. And for the cases of transclavial approaches, we also put a piece of fat graft in order to avoid encephalocele of the pons through the defect. In that way, we avoid complications. The use of lumbar drain in these patients, we put a lumbar drain for very large defects in the anterior cranial fossa and also for posterior fossa lesions. In that way, we diminish the incidence of CSF fistula in these cases.
I see. And I also noticed that you mentioned about the use of the navigations. So I saw that because in transcatheter approach and sometimes you have to drill the jugular tubercle. May I ask how would you identify the anatomy in the endolaser wheel for the jugular tubercle, and also do you use the EM navigations for you to achieve the purpose?
Yes. To perform a far medial approach, which is very rarely used for some lesions, usually we can perform a lateral approach as far lateral, or we can combine the techniques. The EM navigation system is very ergonomic. It allows us to move the head during the procedure to obtain certain angle to work. But in some other instances, we use the optic navigation to treat this lesion. And also, it's very important to address the anatomical landmarks that gives you the first step to identify a normal piece of anatomy, and you can then make the correlation with the disturbed anatomy conditioned by the pathology.
Yes, sir. Thank you so much.
Thank you.
So, shall I invite questions?
Professor Cato, can you make some comments?
Yes.
About this idea?
Me?
Can you make some? Yes. Can you make some comments?
Okay. Thank you very much, Juan, the wonderful talk. So because many the young neurosurgeons want to do the endoscopic procedure, comparing with the microscope. So can you feel any limitation of the surgical procedure with the endoscope comparing with the microscope? Please.
Yes, I think there is a learning curve that we need to follow. As Professor Borba mentioned, we have over 20 years of performing endoscopic endonasal approaches. And for most of our experience is located in the sellar region to treat pituitary adenomas. Okay, then we have the more complex cases, but I advise that in the beginning of the learning curve, we should remain in the sellar region, because this is a safe area. When you are treating lesions extending to the anterior cranial fossa, the transcalabar approaches, to treat vascular lesions, the risk for the patient increases, particularly in the CSF fistula. So there is not a proper recipe to avoid a CSF fistula, but in our experience, the multi-layer reconstruction gives us most of the times the proper reconstruction to avoid the defect. Using these techniques for a patient that can be benefited from a more conventional approach is not adequate. And for that reason, for example, we have stopped to do anterior cranial fossa meningiomas through the endoscopic endonasal approach, because the conventional approaches, subfrontal, transversal, supraorbital, lateral supraorbital, are better and faster, and the recovery for the patient is improving. So we did in some time, but now we have stopped doing this because the conventional technique has shown that it has more benefit for the patient than the endoscopic endomasal.
Thanks so much. Thank you. Excellent conversation. Borba?
Yeah, thank you. Thank you, Juan. I think wonderful presentation, and news that come, new approach, new ideas, always is good. Our next speaker is Professor Paulo Kadri. Paulo Kadri he's just arriving to the hotel in the Brazilian meeting. Let's see how we can connect him. Can you turn on your microphone, Paulo?
Good morning, everybody. I'm sorry I couldn't participate on live. We recorded the lecture last night. I'm just arriving here. I'm driving, actually. Hope any policeman will find me in the street now with the cell phone at my hand. But it was really a pleasure. Thank you so much to Professor Cato, to Professor Borba, to give me this opportunity to also show a little bit of our work. As you see, I'm still driving here. So without further ado, I think that we could start the lecture. And I will be seeing the lecture with you. If there is any doubt at the end, we are also going to make some comments if we have time. It's a little bit long, more than we wish, especially because we have to do that at last night, but I hope you enjoy. Thank you so much.
I just sent to you, Haja, the link, because you need to play from your computer or from Ben computer. Can you play from you or?
I'm waiting. Okay, wait. Please give me a few minutes and I could download it. Yeah, sorry for. Please wait for me for a few minutes. I'm getting the files.
Is there?
Yeah. I'm downloading. Just a few minutes. Please spare with me for a few minutes.
Okay. You know.
Yeah, just
tonight. Tonight is
Yes.
the gala dinner here in the Kyrgyzstan. And they say that there is a surprise to me. Maybe they give me the bill. Huh? Maybe this is a surprise. And I have more 15 minutes to stay here.
Thanks.
I apologize, Professor Guinto had some issue. He couldn't participate, but I think we have wonderful
I think during this time, maybe the fellow from Bangladesh, the lady neurosurgeon from Myanmar. Can you ask some question to Professor Borba or Professor Juan?
Yes, sir. I have one question to Professor Borba.
Yes.
That how he could manage the CSF leak from petroclival meningioma removal. In our country, we are afraid of doing petroclival, petrotentorial, or extensive meningiomatous lesion because we have one fear of CSF leak, and this is disastrous to us. How can he manage?
Yeah, excellent. The people talk about the CSF leak from the nose. We have a lot of CSF leak from the nose, but we also have from the lateral part, from the transpetrosal area. The most important thing when you do any kind of skull-based approach, when you do from the nose, when you do from the lateral, it to be prepared. See, you need to take before open. When you open here, before open the bone, you need to prepare the fascia of the temporalis muscle, okay? And the posterior part of the temporalis muscle. If you see in my previous lecture, you'll find. And you rotate this and put in the cavity. And the dead space, we need to fill with fat, okay? But really fill, because always there is a dead space. And the brain is pulsating and the CSF is pulsating. If you don't do that, it can happen, it will be difficult to close. Very, very often today, I'm using the lumbar drain, but some situation you need to use the lumbar drain. Another thing that is very, very important, the drape. Has to put the drape here in the back and push and hold. See, if you leave, it will be like that. And hold here. This you can avoid a CSF dust collection and leak. Of course, it is theory, is the technique, but not 100%. But the majority of the case, you don't have real CSF leak coming out. We have a collection of CSF in here that you solve with the time or solve with, we put a lumbar drain temporary for 2-3 days and have to close. Okay?
Yes.
Answer to you?
Thank you.
Okay. Now I don't know if Paulo is already in the hotel. Are you in the hotel, Paulo? Oh, yeah. Oh, now you have a special.
Hey,
Now
hello.
he's in the car. You have a special guest.
Yes.
You know the special guest there, Dr. Kato?
Yeah.
Do you know the guy that is you know the guy of Dr. Paulo?
Clearly.
Osama Al-Mefti. Hello, Professor
Oh,
Al-Mefti.
really?
Yeah.
Hi, I'm FT. How are you?
Paulo, turn on your microphone.
Unmute,
Turn on
please.
your microphone, Paulo.
Can
Okay,
you
good.
hear us?
Okay.
Yeah, now I can hear you. Hello, Professor Al-Mefti.
Hi, I'm FT. How are you?
Good morning, webinar. We want to learn. So good to be with you.
No, thank you very much
you so
for
much.
such
We
a
have a special
coincidental.
guest with
We are so
Al-Mefti.
happy to see your face.
Yeah, don't know, Professor. This is the work that Professor Kato is doing during many, many years, helping a lot the young generation. You see?
Just I pulled
Now we have a lot of people is going around. Another guy that's coming here, Professor Kato. Look at this guy.
Oh. Hi, how are you? How are you?
Here, he's here also in Kyrgyzstan.
Kyrgyzstan. Okay. Are you happy?
We are very pleased.
Kyrgyzstan?
We have here people from Kyrgyzstan, Uzbekistan, Kazakhstan, Tajikistan,
Oh, good.
Uzbekistan.
Excellent. Okay. So
All the
international
Kistan are here.
people.
Beautiful.
Beautiful.
Okay.
Beautiful. Is that Noor up there too?
I think it's
Yeah,
short
no,
enough
no,
time.
she's not.
Maybe shall we start?
She's watching. Nor
Yes.
is watching.
And
Okay, please.
I think just now, Professor
Happy
Borba,
to see everybody. Yeah, thank you.
Best regards for all friends.
Today we have a full start.
Yes.
Yeah, go ahead.
Yeah.
Go ahead.
Go ahead.
Professor Paulo Kadri.
Borba, I want to thank you so much on behalf of all the neurosurgeons on the world to continue this education for everybody.
I want to thank Professor Kato. She's making the difference.
Oh, he had the beautiful things to teach.
Thank you.
So happy to see you. So all the best
Yeah.
in Brazilian meeting. Al-Mefti, thank you very much.
Thank you. Thank you. But
now-
please go ahead.
He's
Go ahead,
recording.
man. Now,
Okay, I'll pay
the
now.
great Kadri.
Thank you very much.
Go ahead, please. Thank
Yeah.
you.
Thank you very much for the invitation. It's really a pleasure to be part of this webinar of the Asian Congress of Neurosurgery, together with the Federation of Latin American Neurosurgery, with the invitation of the President, Professor Kato, and our President, Professor Borba. So we changed a little bit the subject because of the rush in the hours, let's say like that. So we're going to focus on the importance of the neuroanatomy to deal with very challenging lesions. And in this case, we're going to talk about lesions on the fourth ventricle. Although with all the technology, we know that our main guidance is still our acknowledgement of the structures that will compose this very critical structure, that is the fourth ventricle, which is composed by elements of the tegment of the pons and the bulbs. For that, we choose a benign lesion. We choose a patient with 42 years old, previous completely safe without any kind of deficit that started with dizziness in diplopia on the lateral gaze, especially to the left. And as you can see, and I will not discuss the image, but this is a cavernoma within the tegmentum of the pons, and we know that the pons is divided in what we call the base and the tegmentum. And I'm going to explain that in anatomical terms for you, but this is for sure the tegmentum, because part of the tegmentum, the very dorsal portion of the tegmentum, is the floor of the fourth ventricle. But mainly the discussion is these lesions abducting, going to the surface of the fourth ventricle or not? If not, how should we deal with this lesion? Should we wait for a second bleeding, which might be devastating? Should we go from the so-called safe entry zones towards this lesion, which might be in this case from the lateral? So in this way, we avoid the fourth ventricle. So this was a big discussion in our department. And we decided to go through the floor of the fourth ventricle. Even we were very afraid that this lesion will not show up, and we might not be able to go through the floor of the fourth ventricle. And this is not a new discussion, as you know. This is a discussion that from the primordials of the neurosurgery, it has been coming from. One of the ones that mostly worked with that was Cranio and Craig, actually. Craig. So they really discussed a lot. Even Dundee later on proposed that any lesion through the fourth ventricle should go over the vermis. And still a lot of people do that. In fact, he used to say that no problem would raise up for us to sever the vermis. Although he said that for other lesions too. But we do know that the cerebellum is a very important structure. For us to make a point of that, we know that almost 50% of all the neurons are located in the cerebellum, although less than 10% of the total weight or volume of the brain is composed by the cerebellum. So we cannot imagine that the cerebellum itself is something silent, that we can just go through it, and that there is no major functions associated with that. Nowadays, we know that the cerebellum is very important, not only in coordination, but even in emotion and in the very high functions of the central nervous system. Later on, we're going to have the discussion on how to go there without damage any portion of the brain. And that was the main concept of Professor Yashterby, the so-called lesionectomy. He used to say that we should try to go to the lesion as a thief, remove the lesion, and leave the whole environment as untouched, as a thief, as nobody never even think that we had been there. There's pure lesionectomy. Then we do have the very well description, very talent description of the group of Professor Rod that started with Matsushima and later on was really very well illustrated by our Brazilian friend also, Antonio Mussi with beautiful illustrations of the so-called telovelo medular, which is exactly, but well described with more pictures of what Professor Yasher Gill called the uvulotonsillar approach. For that, we do have to know in details the anatomy of the cerebellum. So here, we can see the pyramid, the tonsils, the uvula. The uvulotonsillar approach is exactly this highway, this fissure between the tonsils and the uvula. Once you open that, you're gonna see the insertion of what we call the inferior medullary velum. So you can see this membrane that's inserted on the lateral wall of the inferior limit of the fourth ventricle, from what we call the tinea, all the way to the lateral recess. So this is the insertion, this is the tinea that it comes with the extension of the flocculus towards the tonsil. Within this level, we're going to see that there is a pathway of connections of the flocculonodular nodule. Within the inferior portion, here is what we have the open of the medial aspect, dorsal medial aspect of the fourth ventricle that we call the margem D. Continuation of the margem D foramen downwards, or the fourth ventricle downwards, will be the central canal of the medulla. Once again, see here the insertion of the pila, where we have the inferior velum, which is the connections that we have between the flocculus and the tonsil. The nodule, not the tonsil, the nodule. With that, we see that there is this velum, this very thin layer of ependyma that will extend all the way to the border, where we have the insertion of that, and that's the limit, what we call fourth ventricle medially, and laterally the lateral aspect, dorsolateral aspect of the medulla. We do have this presented in this article, very interesting article, where we present the deep nuclei and the connections of these nuclei of the fourth ventricle. But for us to start to unveil this very sacred, this very holy portion of the brain, of the encephalon, let's say. So here we see the fourth ventricle from a posterior view. We're also gonna see it from the ventral view. So this is divided in two portions. One superior portion, which is related to the pons, and then an inferior portion, which is related to the medulla. We do have to know that the medulla has a closed portion and an open portion. This closed portion, as you know, is where you have the transition of the cervical medulla to the bulbar medulla, or to the cranial medulla. So where we have the posterior aspect of the spinal cord transition towards the bulbus itself. And then this will open in a cavity that will be covered by the inferior tila, and where we have the flourishment coming towards the surface of the structures of the tegmentum that were on the spinal cord related mainly towards the central canal. And here we can see better all the way this opening towards the transition also between the pons to the mesencephalon, where we started with the aqueduct. And then we can see here the superior medullary valve, which the lateral aspect will be the superior cerebellar peduncle, which is the main efferent of a deep nuclei of the cerebellum, that is the dentate nuclei. Between them, we do have the superior medullary velum, which different from the inferior medullary velum, we do have gray matter related to it. That's gonna be the lingula of the cerebellum. And on the very medial aspect of that, we can see the fastigial nuclei. So at this point, we can see the deep nuclei of the cerebellum. We can see here the dentate, very clear, demarcated. The dentate with very strong connections with the flocculus, very strong connections with the flocculus. And then we have the fastigial nuclei on the midline, practically on the midline, and then the two other nuclei that together we call the emboliform nuclei. Now, if we see the fourth ventricle, it's marked by a single midline sulcus, and that is the posterior sulcus. Lateral to it, we have two eminences, the median eminence, that will extend all the way from the mesencephalon towards the lower part of the medulla. Lateral to it, there is the limiting sulcus, the limiting sulcus. The limiting sulcus that is supposed to divide what is motor from what is sensitive. Within the midline sulcus, the limiting sulcus, we will face some depressions. The most important depressions is what we call the superior fovea and the inferior fovea. Superior fovea and inferior fovea, so some depressions. A very marked structure, which is for me the most important structure to guide us in the floor of the fourth ventricle, are the so-called medullary striae. Those were once called also the acoustic striae. So they divide superiorly the pons, inferiorly the medulla. Inferiorly the medulla. Now, why is that discussion important if we should access those structures without transgressing the vermis? Because we know that there are defects related to the cutting or destruction of the vermian structure, especially in the inferior portion, the so-called posterior fossa syndrome, which is the mutis, dysarthria, and dysphagia. They are not really related to cranial nerve deafness. And it's kind of question if those are the connections between the cerebellum and the lower portions, and the nuclear rubus and the thalamus. The first one to describe or to use the name state entry zones was the late Professor Piccolo. And he described several entry zones within the posterior, the rostral aspect of the brainstem. However, we do have to consider that these entry zones might not be that safe. So once again, coming back to our anatomy, that's I will say this is the main point of our dissection here. We do have the midline, we do have the acoustic stria or the medullary stria that will go all the way extending towards what we call the vestibular area within the lateral recess that will open within the lusca. You know that the lusca has also the extension of our inferior medullary velum, which is the attachment also of our choroid plexus that will extend through the lusca towards the most medial aspect of the cerebellomedullary, of the cerebellopontine angle. Lateral to it, once again, what we call the limiting sulcus, and then we have those depressions that I told you before, the superior and the inferior medulla, fovea, and notice that on the upper side, almost between the transition of the pons and the mesencephalon, there is a very dark area that is mostly covered by the superior cerebellum peduncle, which is what we call the nucleus ceruleus, the area ceruleus, which the name comes from the bluish aspect that it has. On the superior aspect, we have the beginning of the aqueduct that is marked by the frenulum. Frenulum, where we have underneath the inferior peduncles, the inferior colliculi, the decussation of the fourth ventricle. So here we are seeing the posterior aspect of the mesencephalon, the quadrigeminal plate, superior colliculi, inferior colliculi, the cruciform sulcus with the horizontal portion. Within the horizontal portion, we have this extension that we call the frenulum. Within the frenulum, you have the decussation of the fourth ventricle. Superior cerebellar peduncle, which is the extension or the efference of the dentate nuclei of the cerebellum. You see the connections here of the flocculus, very important connections of the flocculus with this area also, that's the so-called vestibular area. So the limiting sulcus divide this medial aspect, where you have this eminence, because it's protruding. This eminence that's called medial eminence. Most of the structures medial to the limiting sulcus, they have motor function, while those lateral, they are mainly related to sensitive and autonomic structures. See here once again, the medullary strias, very important guide for us. They will be very important for us to guide us in this surgery. And once again here, these structures. Now, within the median eminence, sometimes you can see some bumps. And these bumps will be very important for us to guide where we are within the fourth ventricle. Most of the times when you have a pathology, you cannot face these structures as we are seeing here. But if you can recognize like the midline and a little bump, then you can reconstruct in your mind the whole anatomy of this region. So in this case, if you see the midline, if you see the stria, you see a bump, you know that this is the facial collicular. Sometimes very well demarcated, sometimes very flat and very hard to be identified. Lateral to it, is where we find the superior fovea. And superior to the superior fovea, you can see here this bluish locus or area ceruleus, bluish area. If we dissect, and this is by just removing the ependyma, it's a very straightforward dissection that I will encourage all of you to do if you have the specimens. You just remove a little bit of the ependyma, like this side is untouchable, untouched, and this side we just remove the ependyma. You start to recognize these structures. So here is the facial collicula. Here is the stria medullaris, or acoustic stria. Here I can see, just underneath the facial, I can see actually a grayish nuclei. And this is not the facial. This is the 6th nerve nuclei. The facial is located a little bit more ventral and more lateral and turn around it. So this is the so-called knee of the facial nerve within the 4th ventricle. Now you can see here, this stripe is the cochlear nerve. Cochlear nerve is the only one that goes dorsal towards the floor of the 4th ventricle, although it has a ventral and a dorsal nuclei. So this is the dorsal nuclei of the cochlear nerve. This is the so-called Arnold tubercle or acoustic tubercle, and it's located where? On the lateral recess of the 4th ventricle. This is the opening of the foramen of Luschka. Opening of the foramen of Luschka. This is the guide nowadays where we try to put our electrode to the cochlear, to the brainstem auditory implants. We try to recognize the dorsal nuclei of the cochlear nerve. Here we can see now on the division what is the pontine and what is the medullary or bulbar portion of the 4th ventricle. Let's see here a little bit. In this not so dissected, we can see the medial eminence, we can see the superior fovea, we can see the locus ceruleus. We know that this aspect, these fibers coming upwards, they will mainly be connected or related with the vestibular system. Deeper to that, we're going to see, and we know that there is in the midline a connection between all the nuclei, motor nuclei, from the 3rd nerve towards the 12th nerve. This is the medial longitudinal fascicle. A very strong connection is between 6th and 3rd nerve. But we know that all of these are connected. Within or related with the superior fovea, we're gonna see the motor nuclei of the trigeminal nerve. I'm gonna show this later on because we do have to do further dissections to expose this nuclei. In this, embraced by the cochlear nerve, we know that this is the inferior cerebellar peduncle. Of course, in these pictures, we are not seeing there because we removed the cerebellum, but we can see the continuation of that with the lateral aspect of the medulla. I'm going to touch on that in a moment. So the medullary stria dividing the inferior aspect and the superior aspect. Also, we do have to remember that the limiting sulcus divide this motor portion medially from what we call laterally. All this area laterally we call vestibular area. Vestibular area. Because here we will find the superior, the lateral, the medial, and the inferior vestibular nuclei. And they will have different connections. They'll have connections towards the mesencephalon, they'll have connections towards the spinal cord, as well as they'll have connections towards the cerebellum. Now, on the inferior portion, on the medullary portion, we do have to recognize that when the posterior funiculus of the medulla coming up, it's formed by the gracile and the cuneiform fascicles. They will reach the gracile and the cuneiform nuclei that will form a bump that we call the tubercles, gracile and cuneiform tubercle. Those are outside the fourth ventricle. And then the central medullary canal opens up and form what we call the obex. This opening will form a triangular portion within the floor of the fourth ventricle. And because of the distribution of the arrangement of the fins, it looks pretty much like a pen. That's why it's so called the thalamus scriptorium, or pen in Greek. And within this pen, you can see what we call the hypoglossal triangle and what we call the vagus triangle. This is a close-up, and we can see better the medullary stria. We can see here the hypoglossal and the vagus triangle. Now, on the very deep of that portion, we do have the other continuation of the nuclei. So we're gonna see all the relation of the what we call the mixed nerves, like the vagus, hypoglossal. Those are related with the facial. This is the trigeminal. This is the facial cochlear complex. This is the facial nerve. Once again, this is the turn of the facial nerve, and this is the sixth nerve. But you can see that there is like a gray matter continuation that was the bridge that we can see within the spinal cord. This is the posterior portion of the medullary canal. This is the area postrema. Just anterior to the area postrema, you have what we call the funiculum separans. Funiculus separans. Here we can see the cochlear nerve embracing the inferior cerebellar peduncle. Of course, we can further expose all these structures. Like in here, this is the trigeminal nerve, and now we can see here the nucleus, motor of the trigeminal. We can see here the continuation of the facial nerve, which will receive fibers from the superior salivatory nucleus. So this is the origin of the intermediary portion of the facial nerve. Here we can see now a dissection from the ventral aspect of the facial nerve turning around the nucleus of the sixth nerve and receive from the superior salivatory nucleus the intermediate branch to form the facial nerve. And those are passing just dorsal to the spinal portion of the trigeminal nerve. So this is a very complex area. Of course, we cannot identify all of these when we are doing the surgery of the fourth ventricle. But we can expect, if we have those structures in mind, that we can reconstruct those structures and we can avoid or navigate with that. Not that you can go through that, but you know where you're going to. So once again, in this dissection, I can see the gracile tubercle, the cuneiform tubercle, the obex, the area postrema, the funiculus separans, the vagus triangle, the hypoglossal triangle. Lateral to this is the so-called vestibular area that was dissected, so it was removed. So I'm deeper on that. So what I'm seeing now, I'm seeing the nuclei and the connections that will go towards the surface within the 9th and the 10th. So this will gonna be seeing the nucleus ambiguous and the tractus solitarius, as well as the dorsal nuclei of the 10th nerve of the vagus. Of course, we'll try to close this arachnoid. This will avoid the adhesion between the dura and the cortex, as you know. Then we start opening the tonsils, between the tonsil, and then we'll go through the tonsil or uvulo-tonsillar or tonsil-ovular sulcus, between the tonsil and the uvula, exposing in this way the floor of the fourth ventricle. We'll have to deal with the pica, with the loop of the pica. Remember that although it's always a discussion if the pica has at this point any branch going to the brainstem, I prefer to keep the pica towards the brainstem. So we dissect through the cerebellum. And then we find the choroid plexus, and then we promptly realize, here, now I have a landmark. I can see here what? The medullary stripe. So now I know. Upwards, I have pons. Below, I have the medulla. Our lesion was within the pons. So I do have to keep going upwards. You keep going within the arachnoid layer, avoiding any coagulation, and exposing, releasing all the adhesions. And then we further go upwards for our lucky, the lesion come to the surface. So once you release, we can place a retractor or a sustainer, let's say like that. And now we gently start to remove the hematoma. And the hematoma is the easiest portion. But what we do need to make sure that we're going to remove is the live aspect of the cavernoma. So we keep within the hematoma, and then we start with a counter pressure to remove smooth and trying to keep the plane within the white matter and the wall of the hematoma. Minimum, you do have to save what we call the deep venous anomaly. Don't coagulate that vein. At the end of the procedure, we are going to close again the arachnoid. This will avoid, we put some small stitches, this will avoid later on the adhesion between the cortex and the dura, which might sometimes be related with some complaints, especially of pain. And this is after surgery. You can see that still there is some hemosphedering, but you barely can see if we open or if we did not open the posterior aspect. Before surgery, she had minor symptoms. And this is her 2 months after surgery. So the main concept for us here is that in this kind of surgery, we do have to have a minimal retraction of all structures, minimal coagulation, avoid coagulation. Neuromonitoring is essential. In our reality, sometimes we don't have it. So we do have to rely on neuroanatomy. But neuromonitoring, I would say that is really one of the main aspects of this kind of surgery. If you do have the chance to use intraoperative imaging, and sometimes we do have to use endoscopy to make sure that we did remove this benign lesion and provide surgery or cure for our patient. So I would say that in fourth ventricle surgery, neuroanatomy, neuromonitoring, they are the key aspects. Very gentle surgery with very deep acknowledgement of the neuroanatomy is the essential keys. I'm sorry that I will not be able to be with you during the
Thank you so much, Professor. Can you just give a wrap up? Because you are obviously with us now, and it's indeed so glad to see you and also see Professor Elmith. Shall we invite Professor Elmith or Professor Kadri to speak a few words? I'm afraid we don't have time for the questions because we are going to start another webinar very soon.
Prof.Paulo, Kadri, can you unmute your mic, please? Yes.
Well, thank you very much, Paul. It was wonderful talk. Thank you very much. So the neuroanatomy is really, really important, and also the techniques that you taught us a lot. So the coincidentally, the Professor Almefti.
Yes, Prof.Andrei.
Can you, Almefti? Can you hear us?
Thank you.
Thank you very much for joining us. We are so honored to see your face. So can you make some comment or some encourage for YNS from all the Asian young doctors, please?
She just can't comment.
Thank you so much, because you all learning the right thing. That eagerness to learn microsurgery that's based on detailed knowledge of the anatomy. That's how you could cure patients. At the present, all of this alternative thing does not help the patient because it's a short time control, they call it. What you have seen right now, it's to know how to give the patient cure. But to do that, you need to do exactly what you're just doing right now, to learn both the beautiful anatomy and the microsurgical technique. So I thank you for the eagerness to learn this thing, because you're gonna make a lot of difference in many patients' lives.
Thank you.
That's the way to learn.
Thank you, Amapti. So once again, thank you, Paul, that your taught us so many key issues in neurosurgery. Thank you very much. So Dr. Ben, maybe some closing remark? Yes,
Thank you so much indeed. And I would like to thank all of the speakers today for this quick webinar for the FLANC section. It's, indeed, we wish more sections with you guys so that we could learn so much, learn more about the anatomy and the technical tips. The time is short, and we are going to host another webinar now. But indeed, thank you, and we hope to see you all again on another occasion. So I think our awareness here will definitely benefit from you, from all of you, and we will definitely try to visit to your place if possible, and to learn the attend workshop and do the anatomy process, and to learn from all of you. So so it's time to say goodbye to all of us, and I indeed thank you to all of you, and I hope we'll see you all again very soon. Thank you so much.
Thank you very much. Have a great meeting in Brazil. Thank you very much.
Thank you so much.
Thank you. Thank you all.
Much.
Bye.
Good to see you, Paulo, Professor Mefti.
Yeah. Thank you.
Nice to see you too.